Good morning, everyone. Good morning and welcome. My name is Karen Tucker, and I'm CEO of the Churchill Club. Very nice of you to come out and join us for this program this morning. Today is International Women's Day, and I hope that we can all acknowledge and celebrate that in our own meaningful way. You might know that Churchill Club is an independent nonprofit business and technology forum. Our mission is to encourage innovation, economic growth, and societal benefit. The topic of this conversation this morning has the potential to contribute to all three of these things. It is called IgG4 RD Advances, a revolution in the making. Just about unheard of until maybe a decade ago. IgG4-related disease is a multi-organ immune-mediated condition that mimics many malignant, infectious, and inflammatory disorders. Recently, researchers have made great strides in identifying new clinical features and possible drivers of the condition, unraveling its immunology, and developing effective therapies. They believe that the lessons that they are learning, in particular about human immunology, have huge potential for general understanding and likely specific therapies for other types of diseases, from potentially curing autoimmune conditions to different types of cancers. We owe these gentlemen a debt of gratitude for the work that they are doing, and also the catalyst and sponsor of this conversation is Dr. Sean Nair, who is with us this morning. Dr. Nair has a very keen interest in furthering research to advance understanding of the workings of the human immune system and to create new opportunities for medical breakthroughs. And it is our hope, by bringing you all together in this room this morning, that you will spark conversations among yourselves, get new ideas, new connections, that you too might be part of this amazing time and opportunity. We are privileged to have with us speakers John Stone, Professor of Medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at Massachusetts General Hospital, recognized as the world's leading clinical investigator in IgG4-related disease, and Bill Robinson, Associate Professor of Medicine, Immunology, and Rheumatology at Stanford University. Dr. Robinson is applying technology to discover targets in IgG4 and other autoimmune diseases. So finally, we are very grateful to Fenwick & West for hosting us this morning, as they have so many times over the decades of Churchill Club's existence. Let's now welcome our speakers, John Stone and Bill Robinson. Thank you.
We're going to go over there, I think.
Good morning. So this is a very timely conversation we're having, in that there's many different diseases that we see clinically where we suspect it's autoimmune, but we really don't definitively know that, and the etiology of those diseases aren't defined. And so, for example, I remember back when I was in clinical training at UCSF, and we had a series of patients with retroperitoneal fibrosis for which we had no idea what the causes were. And we ended up, treating them with very primitive types of therapies like colchicine without much effect. Perhaps you can tell us a little bit about how IgG4 became to be recognized and what some of the first insights were.
Thank you. First, let me say it's a pleasure to be here with you. Bill and I discover we actually go back a long way. I was a fellow at UCSF in rheumatology when Bill was an intern, and Bill is from Southborough, Massachusetts, and of course I live not very far from there right now. So I'm really looking forward to the conversation. This began for me about 8 years ago, when a 26-year-old woman from Casablanca was referred to me to rule out Sjogren's syndrome. And she appeared in clinic. I had just come to the MGH in Boston, and she had these very substantial swellings under her chin. And I'd seen a lot of Sjogren's syndrome, but I had never seen a case of Sjogren's like that. And something bothered me about calling her Sjogren's syndrome. And I presented her to colleagues said, "You've got to help me with this woman." And finally, I was persuaded that if she had Sjogren's syndrome, she could also have lymphoma, since some patients with Sjogren's do develop lymphoma. And we decided she had to have a biopsy of one of these glands. The otolaryngologist took the entire gland out, and then the pathologist sat on the case for a couple of weeks and no diagnosis. Finally, I went to the pathology lab myself, sat down at the microscope with the pathologist, and I'll never forget the pathologist said, "It looks like she has autoimmune pancreatitis in her submandibular gland." And I found that to be an extraordinary statement. And then, so I began to read, and there was some literature emerging from Japan. In 2003, Japanese investigators had identified that there were patients with what they called sclerosing pancreatitis, we now call autoimmune pancreatitis, who had extrapancreatic features of the disease. They had the same kind of pathology in a variety of different organs, including the submandibular glands. And so that's how this emerging entity came to my knowledge. And in looking back further in the literature, it was astonishing to find that there are pictures from the German medical literature in the 1890s, drawings of patients who clearly had IgG4-related disease then. So it's not a new disease. It's a disease that has been around. And Japanese colleagues really came up with a wonderful metaphor for the disease. They describe it as being like a crow flying through the night of medical history, because it was there when you were an intern, and you missed it then. And it was there when I was a fellow, and I missed it. And it's been there for decades and goodness knows how many centuries. And it took until this century and a confluence of circumstances for it to begin to come to light. And now, once we became aware of that patient, we realized there were patients in our clinic who were being followed for other things, for Sjogren's syndrome, other diagnoses. And lo and behold, when we looked at their serum IgG4 concentration, or when we went back and looked at biopsies that they had had years before, then we found they had IgG4-related disease as well. And patients really started to come out of the woodwork. And I'm pleased to say that an international collaboration has really grown up around this. Just a couple of weeks ago, we held the third international symposium on IgG4-related disease and fibrosis in Hawaii, because it's right between the continental United States and Japan, so investigators from both places can descend on the symposium.
So it seems, since your original kind of insights that this might be a distinct disease entity, the kind of the umbrella of different clinical syndromes that fall under this diagnosis has broadened to a whole bunch of other, kind of involvement of other organs in the body. Can you speak to kind of the spectrum of IgG4-related disease?
So in the early days of this, which goes back only 7 or 8 years now, it was a eureka moment almost every week when we would have a patient sent to us and we'd realize this patient has this disease in the lung. Or the pathologist would send a patient who had had a prostate biopsy or a prostatectomy, and lo and behold, it was IgG4-related disease in the prostate gland and not prostate cancer. Or it was in the lacrimal gland in the eye. And I used to say that the disease can involve every organ in the body except the brain. And now I know that that's not true, because we've seen several patients with parenchymal brain involvement. So the disease can involve literally any organ in the body, and it is very important to diagnose it for a variety of reasons. One of them is that the disease is often mistaken for cancer. I was at Johns Hopkins last week. They presented a case to me of a young man who underwent a modified Whipple procedure. They removed basically his entire pancreas because they thought he had adenocarcinoma of the pancreas, and it turned out to be IgG4 related disease. That patient ultimately died after several years of not being diagnosed, several different opportunities to make the diagnosis with different biopsies of different organs, and nobody put it all together. So it's important to make the diagnosis because it is treatable. It's important to realize that it's not cancer, so patients don't have inappropriate operations, or they don't get treated for other immune-mediated diseases such as Sjogren's syndrome or primary sclerosing cholangitis. One of the real delights for me with this disease is that this disease, the study of this disease, permits us to go from a clinical finding, swelling of the submandibular glands, swelling of the eyes, to findings in the blood, to findings in biopsy tissues, and then to apply really cutting-edge molecular biology techniques to understand how this disease works now. I have relearned immunology that didn't exist when I was in medical school through trying to understand this disease.
So, yes, and I think we're going to spend quite a bit of time talking some more about pathogenesis and pathophysiology. Can you touch base for a minute about this association with allergies and allergic responses in a subset of IgG4?
That's a great question. It's an area that we don't fully understand yet, but a lot of our patients do have atopic, allergic kind of symptoms. And it was thought, as a result of that this must be a Th2-driven process. Certain kinds of T cells must drive this. But that notion has been debunked now with our ability to look very carefully at the cells that are driving this disease. And maybe we could move into pathophysiology a little bit now as a result of that. One of the let me ask you, what are your current thoughts about the pathophysiology mechanisms and what the key players are in the disease?
So for many autoimmune diseases, we always wonder why it targets the organ that's being targeted. And in certain cases, for example, in type 1 diabetes that Hugh McDevitt and Greta Sundestrup investigate, there's good evidence that there's autoimmunity against insulin and beta cells of the pancreas. But here we have a disease that's affecting many different organ systems, and the antigens aren't clearly defined. And so, trying to think about why, perhaps the salivary glands or the lacrimal glands are targeted in some patients, the pancreas in others, and the retroperitoneum in yet others, and that constellation of diseases. Obviously there's been significant advances in technologies that let us study the immune system in unprecedented ways, and I think you and Shiv Pillai, one of your colleagues, have done a very elegant job starting to define the types of T cells that are aberrantly activated in IgG4 and showing that there's expansions of T cells in the lesions of your biopsies, both kind of some of the first an atypical set of T cells that I'm interested in hearing these CD4 cytotoxic cells that are making both cytokines such as TGF-beta and IL-1 that can potentially drive fibrosis, but also making mediators such as granzymes and perforins that can actually cause damage to cells. And I think that their expansions in the lesions definitely suggest that they might be involved in mediating part of the pathogenesis. I don't know, do you have comments on that subset? And then there's another key subset, and that's these T follicular helper cells that we think are really coordinating the antibody response. So, what are your thoughts about
this T cell, which is indeed fascinating? We think it's the crux of the disease, but we got to it in a roundabout way. we first approached it from the standpoint of the humoral immunity side because of all of the IgG4 that was present in the blood of these patients. I mean, these patients are sometimes thought to have a plasma cell dyscrasia, a malignancy of the bone marrow because their IgG4 is so high. And one of the very early findings was that these patients have enormous concentrations of plasmablasts, which are descendants of B cells. Of course, we can target B cells directly now with anti-CD20 therapy, rituximab. And anti-CD20 therapy works remarkably well in this condition. That was another eureka moment, identifying that. But these plasmablasts show signs of somatic hypermutation, really suggesting they have been interacting intensely with T cells within lymph nodes or in extranodal lymphatic tissue. We had so many of the insights from this disease have been driven by individual patient observations. We had a patient who had classic IgG4-related disease and disease of the skin. And the diagnosis was made by the dermatologist who biopsied her skin papules and was told that it looked like she had IgG4-related disease in the skin, or autoimmune pancreatitis in the skin. And so we treated that patient with rituximab, and then she had a dramatic clinical response. We went back 5 weeks later and biopsied the site of one of those skin lesions. And we found that, not surprisingly, the B cells were gone from the skin lesions, but also the T cells were depleted. A dramatic example of how B cell depletion influences T cells. So we began looking in peripheral blood at T cells, at the CD4 effector T cells, with next-generation sequencing. And very quickly, a very striking oligoclone popped out of one of our patients. And we found that all patients with IgG4-related disease have a striking oligoclonal expansion of this CD4-positive cytotoxic T lymphocyte, which is probably not the T cell that is causing the class switch. That's the T follicular helper cell. But this CD4-positive cytotoxic T lymphocyte is a novel T cell. It has been identified in a few other diseases, but it hasn't been phenotyped as carefully as we've been able to do. We see patients, we make the diagnosis ourselves typically. We see them before they have received any kind of treatment, not even 40 milligrams of prednisone for a day. And that has allowed us to really explore the biology in a clean way. But as you've alluded to, these CD4-positive cytotoxic T cells make IL-1, IL-1 beta, TGF, transforming growth factor beta, interferon gamma, and all of those products could really drive the fibrosis or the scarring, which is such a key feature of this disease. Sure. So we've been able to, in a very short time, the disease has been known for only 12 years or so, we've put together a pretty coherent model of the pathophysiology. And that is that I like to refer to it as a B-cell, T-cell dance, which goes on in this disease. B cells and plasmablasts are presenting antigen to this T cell and sustaining the CD4 positive cytotoxic T cell. And the T cell, in turn, is elaborating these different mediators which cause the fibrosis and the cytotoxic injury. And we're able to observe the biology so purely in these patients. If we treat them with an anti-CD20 therapy, not only do the B cells go away and the plasmablasts go away, but this CD4 cytotoxic T cell also declines over weeks because it's not sustained. It doesn't have the continuous antigen presentation.
Those are intriguing observations. I think in several other diseases where they've seen cytotoxic CD4 T cells, such as in HIV disease and in certain diseases, there's chronic antigen stimulation. And it might suggest that there's a persistent antigen that's kind of driving the response in IgG4, also as evidence to the fact that there's such extensive, we call it affinity maturation or mutations in the B cells from repeated cycles of activation. So what's causing these B cells to make IgG4?
That's a great question. And ironically, we've come to view the IgG4 as being probably a counter-regulatory mechanism. We think it's not driving the disease. And this gets to the other part of that B cell, T cell dance, which is between B cells and plasmablasts and another CD4 positive T cell, the T follicular helper cell. And our group has been doing a lot of work in this area very recently. T follicular helper cells sit right outside the germinal center, as it turns out, and they drive the class switch, causing these B cells to convert to cells that make IgG4. And we think that is an ineffectual counter-regulatory mechanism trying to suppress that primary immune response. And the IgG4 just builds up and gets higher and higher and higher in the blood. It's probably by nature an anti-inflammatory antibody itself. It doesn't activate complement. It doesn't bind Fc receptors. So it itself should not have an inflammatory effect. We think its role may be to go into sites of inflammation and bind up antigen without making the inflammation worse, serving as an antigen sink, in essence.
And you don't need to be IgG4 positive or elevated to have elevated IgG4 to have the diagnosis of IgG4-related disease. Is that correct?
That's exactly right. Only about 70% of patients with this disease have elevations in their serum IgG4 concentration before treatment. The range is enormous, though. So the range in the blood can go from normal to 30 or 50-fold the upper limit of normal. And we think, just to sort of complete the biology, once we treat patients with an effective therapy, the IgG4 concentration doesn't normalize, even if they've had a terrific clinical response. Rather, it falls very slowly over many months or years. And we think what has happened is that there are plasmablasts that were making the IgG4. They have some have homed back to the bone marrow, where they become long-lived plasma cells, and they continue to make IgG4 for a long period of time.
So in many autoimmune diseases, we always think that there might be an infectious microbial trigger, or in, for example, rheumatoid arthritis, we think that there's an environmental trigger, specifically cigarette smoking. What triggers, what triggers do you think might be associated with IgG4? Are there allergic triggers, infectious triggers, other environmental triggers that you think are perhaps initiating this response?
Well, this is where I want to begin to hear about some of your work as well, because antigen discovery is something that we are very interested in, and I'm delighted that with Matt Baker and Justin in your lab, we've struck up a nice collaboration now. In many ways, IgG4-related disease is like just about every other autoimmune disease. It's clear that the immune system is attacking different parts of the body, but we don't know what antigen triggered it. And so I think this is one of the areas where what we understand from IgG4-related disease could have enormous implications for the understanding of autoimmunity in general. Maybe you'd tell me just a little bit about your work in antigen discovery.
Sure. So one of our major kind of areas of focus is taking specific populations of activated cells in the immune system and using them to try and gain new insights into what the targets are in specific autoimmune diseases. And so, for example, in rheumatoid arthritis or in multiple sclerosis that Tobias Lance, who's in the audience, is working on, or IgG4 disease that Matt Baker and Justin Jarrell are working on, trying to take this population of activated B cells, and we're also looking at, in other experiments, activated T cells, and using those to kind of try and identify the actual targets of the autoimmune response. And so one of these cells that is this activated population is these plasmablasts that John was talking about. So these are B cells that have been recruited from both the naive B cell repertoire as well as the memory B cells. And they're the output of the active, ongoing, current immune response. So the power is, this is like effectively what browser windows open on your computer right now at this moment. This is the B cell that your immune response is making at the current moment and the current ongoing response, not the one that got generated when you had the flu a month ago or got a vaccine years ago. And so if you look at this plasmablast population, there's the potential to use the antibodies that it produces as molecular probes or fish hooks to try and identify the targets. And I think, Shiv Pillai and John have, done several iterations of that, and Justin is busy working, championing, an iteration of that in our lab where we harvest these antibodies and produce them recombinantly. It's actually a very new day and age. Back kind of even 5 years ago, it used to take months of work to PCR clone an antibody and to express it in cells, and then to have recombinant antibody that you can use, a monoclonal antibody that you could use to kind of test for things. And now when we sequence antibody repertoires, we can informatically identify, well, first we can sequence at an incredible depth. So we can look at many thousands of B cells all at once. And then we can use informatics to identify expanded B cell families that we believe pinpoint the key B cells being generated in an ongoing immune response. And then we email their variable region sequences to a DNA synthesis facility. They synthesize the sequence and transfect the DNAs, and by FedEx a month later, tens of antibodies arrive back. At all at a kind of $500 an antibody type of price point. So it's a new era for our ability to kind of not only sequence and query the immune system, but then to generate these probes that we can use to try and identify what the targets are. And Justin has married this sequencing and antibody production where we identify all the different key B cells being generated in responses, including in IgG4, and producing the antibodies. And he's married that with what we term antigen arrays, where we print high-density arrays with many thousands of different candidate antigens. And you then probe those arrays with your antibodies and try and identify what the targets are. And so, very interested in trying to determine what antibodies and other immune response targets might be contributing to IgG4. And I think, one of the questions that comes back, you always want to know, I think why certain organs are targeted. And we always like to think in autoimmune disease that it's the antigen in the organ that's resulting in the targeting. Or alternatively, are the antibodies in fact pathogenic? And I think it's very intriguing that there might even be evidence that some of them might be counter-regulatory.
Yeah.
So I don't know what your thoughts are, but I think it's an ongoing process as we try and uncover what the targets are.
Some antigens. I have never seen a patient with retroperitoneal fibrosis who wasn't a smoker. Never. And usually a heavy smoker. And that's interesting because rheumatoid arthritis, we know that cigarette smoking is a risk factor for severity of rheumatoid arthritis. So those IgG4 antibodies that are being made, and they are thought to be a counter-regulatory mechanism. They're feeding back into a site of inflammation. They're binding up antigen, and if you can identify their specificity, then that may tell you what antigen is driving the process. And are B cells then presenting that antigen to the CD4 positive cytotoxic T cell? We can probably get some insight into that based on the T cell receptor. So it is putting together really using absolutely cutting-edge technology to get at the very crux of autoimmune disease.
So it's been quite remarkable that several of these diseases that we think that are classic T-cell diseases, such as rheumatoid arthritis and multiple sclerosis, have turned out to be very effectively treated by rituximab B-cell depletion. And that's a similar finding that you have in IgG4. Perhaps you can tell us a little bit more about treatment and how, what the next generation treatments might be for IgG4, because obviously rituximab's depleting many peripheral B cells, and although effective, perhaps there's ways to approach IgG4 that might even be more specific as opposed to this broad depletion of B cells.
Yes, so our understanding of the pathophysiology of this condition opens up a whole lot of different potential approaches to treatment. First of all, let me say that this is a disease in which one doesn't want to have to use prednisone forever. I mean, this is a disease that affects middle-aged to elderly individuals. It tends to target the pancreas. Many people have already had some of their pancreas removed because of diagnostic misadventures. So having them on prednisone, if they already have exocrine and endocrine failure of the pancreas, is bad. And just like prednisone with most other immune-mediated conditions, IgG4-related disease responds to it, but it is not cured by prednisone. So typically it takes more prednisone than one wishes to have the patient on to keep the disease under control. But our understanding of this B-cell, T-cell dance brings up a lot of possibilities for targeted treatment. So anti-CD20 therapy works very well. And at some point, we may be able to do a worldwide anti-CD20 therapy trial. That would be terrific. But we are also targeting the B cell and plasmablast in other ways. An anti-CD19, a monoclonal antibody, the FAB portions bind to CD19, so cells of the B cell lineage. The Fc portion of the molecule binds to Fc gamma receptor R2b, which is the only Fc gamma receptor on the B cell. And when bound in concert with CD19, it downregulates the cell. So that's also a promising treatment approach. But we think that the real driver of the disease is this CD4 positive cytotoxic T cell, which has an interesting marker on its surface called SLAMF7. And SLAMF7 was not known to be on any T cell before we really phenotyped it carefully. Interestingly, SLAMF7 is known to be on cells of the B cell lineage and plasma cells. And it may be that SLAMF7 is one of the mechanisms whereby the B cells and the T cells interact in this disease. So targeting that molecule or targeting that T cell in some other specific way might allow us to remove the pathogenic cell. This is not a cell that occurs, we think, outside of states of disease. So that would be another approach. The T follicular helper cell has been raised as a potential therapy as well in a variety of diseases. The T follicular helper cell is driving the class switch. But what I wonder about is whether interfering with the T follicular helper cell wouldn't, in fact, make the disease worse, because it would remove some of the brakes on the disease. So it might have the opposite effect. But I think as we understand these, the details of this B-cell, T-cell dance better, there will be lots of targeted opportunities for treatment.
So one question that just kind of, how diseases get their names. So here's a T-cell driven disease that's named after a B-cell antibody product. How did it get named IgG4 related disease?
Well, I think the Japanese are responsible for that. They identified the disease, and they were struck by the dramatic elevations of IgG4 in the blood and the dramatic number of IgG4 positive plasma cells in tissue. And they leapt to the conclusion that IgG4 causes the disease. But biology is often more subtle than that. And we think the IgG4 is there trying to put the brakes on the primary response. So there's a lot of subtlety to this disease, which reminds us how subtle the immune system can be. Could I ask you about the fibrosis issue? And the fibrosis is a huge problem in the world. There's a colleague at NIH who's fond of saying that fibrosis contributes to 45% of deaths in the world. I'm not sure where he gets that statistic, but it is a big problem. It is the end result of a lot of different pathophysiologic processes. And this disease has fibrosis as a major pathologic hallmark. Some of the mediators of this T cell could drive fibrosis. And your lab has been interested in IL-1, for example. Do you want to say a little bit about that and how our work may dovetail?
Yeah. I mean, I think, as you're calling out, fibrosis is a kind of an end product result or pathologic kind of change to tissue in many different diseases, and everything from allergic asthma to even perhaps in the bone in osteoarthritis to different diseases, involving the liver, chronic infections in the liver. And I think, the molecules, there's clearly certain sets of cytokines and T cell responses that drive fibrotic responses, such as you're highlighting for your cytotoxic CD4 cells seem to be producing those mediators. Justin in our lab has been very interested in the roles of IL-1 and TGF-beta and other cytokines in mediating fibrosis and trying to identify whether some of the antibodies that are made might be altering responses, to these cytokines to further promote fibrosis. I think it's a tricky thing. We think of most antibodies, as you're kind of highlighting for IgG4, as not actually causing many diseases. There's certain examples, for example, myasthenia gravis, where a pregnant woman's antibodies will cross into the fetus, and the baby will have transient myasthenia while the antibodies break down over the first couple months of life. But there hasn't been any such antibody transfer studies in IgG4 related disease that clearly demonstrates a definitive pathogenic role. And as you're highlighting, they may even be anti-inflammatory in certain ways. So anyways, I think sequencing, for example, antibody repertoires where you identify the antibodies generated can serve two types of roles. One is you can try and identify their targets, which may also be the target of the T cell response, and thus it can provide the window that allows you to kind of really unravel what's driving the T cell responses in disease. And in certain cases, it may identify an antibody that's in fact contributing to pathogenesis. And so I think, we're busy working to see if perhaps in a subset of patients, some of these antibodies might, in fact, not only just identify a target, but might actually contribute in some way to pathogenesis. And one of the things that, we're always kind of influenced by names of it's coming back to this name question. Justin was very disappointed when he starts sequencing some of the activated B cells, and they're not IgG4 antibodies. And and of course his mentor, myself, says, well, you got the wrong cell, or are you sure your primers are correct? It's all this kind of questioning of the result because of the name of the disease that carries these connotations, and I think it channels our thinking in how we look at our findings and how we think that the mechanisms of disease might be. But I think part of our objective is to try and see if we can use these antibodies to define the targets and perhaps identify an antibody that might actually contribute to the mechanisms underlying disease.
So it's great. As we were chatting before we started, it's really terrific to hear that the work going on independently in your lab seems to confirm some of the findings that we've made with regard to this T cell, because of course validation is really critical for science. Getting back to the fibrosis issue, there are, I think it's fair to say that there are different subsets of IgG4-related disease. The patients who have very high serum IgG4 concentration, multi-organ disease, we knock that out of the park with treatment. And I think we're going to have any number of therapies to treat that subset of patients very well. They may be B-cell targeted treatments, plasmablast targeted treatments, maybe T-cell targeted treatments. But the fibrosis, which is already present at the time you make the diagnosis, that is a much more vexing problem. We did find that B-cell depletion improves fibrosis to a certain extent in that same patient who had the skin lesion. Her smooth muscle actin activity improved substantially after B-cell depletion. But the fibrosis scarring generally doesn't melt away the same way the B-cells and plasmablasts do. So we're trying to target now an understanding of what's driving the fibrosis. The fibroblast, which is clearly the myofibroblast, clearly a very important cell in this process, has been very little studied thus far. So we're now doing co-culturing experiments with CD4 cytotoxic T cell and fibroblasts and plasmablast and fibroblast to try to understand what's driving the fibroblast. Because if we could understand mechanisms of fibrosis in this disease, it could be a very big leap forward. One of the really interesting things is the fibrosis in IgG4-related disease very often responds dramatically to therapy, too. So in the lungs, for example, listening to patients with my stethoscope and hearing classic Velcro-like crackles in their lungs, we treat them, and those things are gone. And that's really very different from other forms of interstitial lung disease. So if we could understand that phenomenon, I think we might have something important to say more broadly about fibrosis.
Yeah. No, the implications for many different diseases where the end pathology is fibrosis is, kind of quite remarkable. The insights that IgG4 disease and understanding it could provide to these other diseases. So,
what do you think about the antigen or antigens? Do you think it's one antigen that drives this disease?
But most autoimmune diseases are driven by networks of antigens. For example, rheumatoid arthritis or multiple sclerosis or psoriasis. But there are certain diseases such as myasthenia or pemphigus or Graves' disease that are driven by single antigens. And frequently, those single antigen diseases are also antibody-associated diseases, where the antibody targets that antigen and has a effect, such as blocking an acetylcholine receptor in myasthenia. My sense is that there's a possibility that there's a individual antigen that could be, for example, a fibrosis-promoting cytokine or other antigen that might provide the basis for an individual antigen being an important antigen in IgG4. But most autoimmune diseases are, there's something called epitope spreading. Epitope spreading is where your immune system evolves from targeting a single epitope or feature on a protein or antigen to multiple different features, and then spreading to other related antigens. And this is how your immune system prevents bacteria and viruses from escaping through mutating the key protein. So by epitope spreading, you lock into the virus or bacteria and prevent it from escaping, but you also cause refractory autoimmunity. And so my sense is likely it's going to be a network of different antigens that are the targets in IgG4, and that it's going to be something that, I spent 15 years of my life working on antigen-specific tolerance, trying to turn off autoimmune responses to driver antigens to tame the whole disease. And in retrospect, after using all these next-gen technologies and seeing the autoimmune responses spread to all these different antigens in the tissue, I'm not sure that antigen-specific tolerance is really the way to approach these diseases. I think that broader tolerization is likely necessary, and I think that that's probably going to bear out in IgG4 disease too.
Our sense is, you're right, that it may be that every patient has his or her own antigen driving it, or maybe it is a network. But if you can turn off the inflammation for a while, 6 months, a year, by disrupting the cells that are involved, you may induce a long-standing tolerance, in theory.
Absolutely. Every time we get an infection or a vaccine, our immune system has homeostatic mechanisms that bring it back into tolerance. So you mount an aggressive response against the flu, and then you downregulate those T cells and B cells to restore tolerance. And so in autoimmunity, that kind of process those regulatory mechanisms fail to restore tolerance. We know that in lupus and MS, people flare and then remit. And so, if there's ways to kind of reset the inflammatory response in these T cell responses, and then to help reinforce these natural mechanisms to turn off and downregulate the immune response, perhaps we could, fundamentally turn off the autoimmune response in IgG4. And that's kind of would be one of the holy grails in autoimmunity. But to date, most autoimmune diseases require chronic therapy, where you can't stop immunosuppressive therapy, and you effectively need to treat lifelong. And I don't know, what are your impressions? I mean, my sense is that IgG4 disease is likely in that category for most patients.
I think patients have their own clocks. Thus far, we may not cure the disease with one course of therapy. We do very often induce long periods of remission. We haven't followed patients long enough to be able to pronounce them cured. But I do think that in the next few years with this disease, we're going to be at a point where we have, maybe the next 10 years, we have a variety of different targeted therapies that can very reliably turn off the disease without requiring steroids at all, much less chronic steroids. And we'll be able to monitor the disease. So we'll be able to know when the disease is beginning to come back. And patients may not need to be treated chronically. They may need to be treated for 3 or 4 months at a time, and then monitor their parameters and reinstitute treatment when it needs to happen. So I think we're going to get there within the next decade with this disease, and hopefully we'll also have some approaches for undoing the fibrosis, which is such a big problem.
Fantastic. So shall we take some questions
Sure.
from the audience?
Dr. Bob.
So I'm very intrigued by the idea that the IgG4 may be anti-inflammatory, similar to how we use IVIG in our autoimmune diseases. So in the patients who are treated effectively, those who maintain a high IgG4 serum level, do they tend to have a longer remission rate than those whose IgG4 level has been abrogated or lost?
No. Actually, the contrary is true. Patients who have a very high serum IgG4 concentration at baseline before we begin to treat them, those are patients who are going to need to be treated again. They are not going to be cured by one course of steroids or one course of rituximab. They are going to flare again.
What about those who were treated effectively and they are, quote, in remission, but you then measure their IgG4 level? What's their likely course?
So it is, we see, this is why the biology of this disease is so interesting. It's taught me so much about human immunology. The plasmablast and short-lived plasma cells are making all this IgG4. We treat the patient with either steroids or B-cell depletion. There's a big drop in the serum IgG4 concentration, but it doesn't normalize. It may come down by half or a third. And then the rest of the, then over months, maybe years, it is required for the serum IgG4 to normalize. And that's because some of these plasmablasts have homed back to the bone marrow and become long-lived plasma cells, and they're continuing to make IgG4. When I hypothesize that when the level begins to come up again, that may be an indication that the patient's primary immune response is acting up again and that the patient may need to be treated. But fortunately, the disease is sufficiently indolent that we can understand we can study and we can understand what's going on with the patient. We don't have to immediately put them on prednisone for fears that their kidneys will fail. Great question. Another question?
In the back. I thought the SLAM F7 research is really interesting. I'm just wondering if there are plans to develop elotuzumab or if it's being used off-label, and then would also love your perspective on if you think the CD19 strategy is going to be superior to Rituxan at the end of the day.
So we would love to target that CD4 positive CTL. One way of doing it might be an anti-SLAM F7 approach. There is an anti-SLAM F7 antibody which is approved for multiple myeloma. It was, in fact, the first drug to achieve a breakthrough designation by the FDA for the treatment of multiple myeloma, because we know that antigen is on the B cells and plasma cells. But it's not clear that an antibody to SLAM F7 would improve IgG4-related disease. So we're trying to study that. And we are developing an antibody. But it's hard to develop a good antibody. And then we have to test it and make sure that it would not have the opposite effect. Because elotuzumab works in multiple myeloma because of other markers that are expressed with SLAM F7, EAT2. And so if we are not careful, we could have the unintended consequence of making the disease worse. We'd very much like to do that, though, and it's an area of active investigation. With regard to the anti-CD19 treatment, we are completing a 15-patient trial. We've reported some of these at the American College of Rheumatology and at the Symposium in Hawaii. And it looks promising. It's a little bit hard to make an apples-to-apples comparison with rituximab, because with rituximab we always give solumedrol with the infusion, and we have typically not given steroids with with this drug, 5871. So it's hard to make an apples-to-apples comparison. It's clear that some patients do very well with this drug, and it has reinforced our understanding of the biology of the disease. But I think we're going to have to do a larger trial in order to understand, a placebo-controlled trial, to really know.
Other questions? Yeah.
This research is very promising. You are targeting to cure the disease and not just treat the symptoms like the pharmaceuticals do. My question is, you are concentrating on IgG4 today in your talks, but how does it apply to other autoimmune diseases like PMR? Because you talked about not using prednisone and doing targeted T cells or B cells. So how does that apply to other autoimmune diseases like PMR?
Well, I think that the steroid sparing is really the mantra of the next decade in immune-mediated disease. Now that we have biologic therapies that work, we recently completed a trial of interleukin-6 receptor blockade in giant cell arteritis, a related disease to polymyalgia rheumatica. And one of the principal motivations for doing that trial was because of all the toxicity of steroids in that disease. Like IgG4-related disease, giant cell arteritis and polymyalgia rheumatica tends to afflict middle-aged elderly individuals who have other comorbidities, who make steroids really problematic. We have worked on something called the glucocorticoid toxicity index, GTI. It's sort of remarkable that we've had steroids now for 67 years, since compound E was discovered at the Mayo Clinic, cortisone. And we all know the bad effects of steroids, but we have never had an instrument that actually allowed us to quantify the toxicity in a weighted way. And with a group of about 20 collaborators from multiple specialties over the last year or two, we've developed such an index. And I think that's going to be really crucial for actually demonstrating not only that we decrease the number of milligrams of steroids that patients have to take, but we decrease the toxicity too. And I think that's going to be very important for the regulatory agencies. In the very back. If you've got the microphone, go ahead.
We heard earlier that IgG4-related diseases can affect almost every organ system. My question is, what about the vascular system? Is there any deposition in arterial walls? And what about atheroma?
Those are great questions. So first, a couple of weeks ago, there was a CPC in the New England Journal of Medicine, one of my patients who presented with, for what looked like for all the world, giant cell arteritis. She came in with headaches, jaw claudication, pain when she chewed. She had swollen, tender temporal arteries. But there were a whole bunch of other things that made us think that she might have IgG4-related disease. And indeed, temporal artery biopsy showed IgG4-related disease in the temporal artery. The disease has been described in the aorta as well. So it tends to affect large blood vessels. So it's unquestionable that it does cause aortitis and that sort of thing. Whether it contributes to atheroma, boy, wouldn't I love for that to be the case. In the abdominal aorta, where abdominal aortic aneurysms occur, there is very often IgG4-related or IgG4 positive plasma cells involved in that inflammation, and there is overlap between retroperitoneal fibrosis and chronic periaortitis, which can lead to pathology in those areas. But it's a big leap to say that IgG4 or IgG4-related disease is involved in some way in atherosclerosis. I think that's unlikely, highly unlikely.
So you talked about treatments targeting the B cells and the cytotoxic T lymphocyte population, but I'm curious about that other T cell population. Do you know what happens with those treatments to the T follicular helper cells?
I don't know, and I'd be interested in Bill's thoughts or speculations, because we've only started to think about the T follicular helper cell in this disease. What do you think?
The T follicular helper cell is a more recent kind of T cell population of focus, and IL-21 is one of the key cytokines that it makes, and there's several antibodies that are kind of, that ultimately anti-IL-21 antibodies that will move forward, and it would be very interesting to see if, blocking TFH-induced B cell activation and plasmablast development, in fact, had an impact in IgG4.
One of the great things about this disease is we can study it. We could go back and biopsy a lymph node and look at the T follicular helper cells following treatment. And I think we'll get there at some point. Tobias?
Do you think the cytotoxic CD4 positive T cell is a misguided T cell which is very specific to the disease, or do you know of any other pathologies where it plays a role?
So the cell has been identified in other diseases. For example, granulomatosis with polyangiitis, formerly Wegener's. Back in the 1990s, it was identified in rheumatoid arthritis. We found it in the peripheral blood of patients with systemic sclerosis or scleroderma. So I think that the cell has been there, and other investigators have noted it before, but they haven't really focused on it and phenotyped it well. Yeah, and Bill alluded to this in his comments earlier. It could have a role in controlling HIV. Or CMV, in chronic viral infections such as CMV, these patients, many of these patients do have this kind of cell. So one of the questions is there some chronic viral infection or something that looks like a chronic viral infection that has triggered this? Maybe that'll be one of the antigens we discover. But we don't know, what makes a cell protective under some circumstances and damaging under other circumstances. It can be a very small thing, it seems, in the immune system that tips it one way or another.
Justin?
So it's great that for a majority of the patients, they respond really well to Rituxan and B-cell depletion therapy. But I'm assuming, like lupus and other autoimmune conditions where they're treated with Rituxan, that a subset of those patients become refractory to B-cell depletion and actually start to develop those symptoms again. And in those individuals, do you see a re-expansion of those CD4-positive cytotoxic lymphocytes and plasmablasts and their ability to secrete more of those cytokines that might be promoting the fibrosis? And then also, for those individuals who become refractory, are there other therapeutic options for them? Are there things like anti-CD38 or anti-CD138 that are being utilized in order to treat that condition?
So, great question. And yes, patients following rituximab do flare. Many of them, most of them flare at some point. Some patients do have very long remissions. But there have been other patients I've had to treat every 3 to 6 months in order to keep them in remission. One patient, every 3 months, if I didn't treat him, his IgG4 went up, his pulmonary fibrosis came back. When we treat them and their disease comes back, we see a clonal divergence in the plasmablast population. So the plasma cells the plasmablasts that come back after remission are different. They're seeing different antigens, which maybe it's different parts of that antigen which triggered the process to begin with. That makes us think that this CD4 positive CTL is probably the real driver, And I would hypothesize that we would see an expansion, a re-expansion of those CD4 CTLs as well. We are really endeavoring to collect samples on patients who've become hot again before they start any kind of treatment, so we can take a really good look at what's going on at a molecular level. In terms of other treatments, there are no one has really investigated anti-plasma cell therapies. I think that deeper B-cell depletion has a lot to offer, potentially. And there are lots of other potential targets as well.
I'd like to thank our speakers for sharing your points of view so candidly. Hope this has been inspiring for you, and I hope that you will continue discussion among yourselves after the program. We do have a very small gift for our speakers today. It is the Churchill Club speaker T-shirt, and we hope you wear that in very good health.
Thank you.
Oh, please. Yes.
Thank you.
Great. Thank you.
Yeah. All right. Oh, this is nice.
We do have a couple of other programs coming up that you might be interested in. You could check your programs. And the first one is May 2nd. It's called Connecting Everything When Everything is in Motion. And then we have another one on the 24th of May called Top 10 Tech Trends, the 19th annual. There's one that hasn't yet been announced that will be announced soon, which is Lord Martin Rees from the UK, who talks about everything from AI to cosmology, etc. So that'll be interesting. We're working on how to frame it right now, but it'll be up soon, April 20. So thank you again. Good day.
Thank you.